All right, today we're going to deconstruct an injury that's way more than just a broken bone. For a lot of people, it's a major turning point in their lives. We're talking about the femoral neck fracture, which you've probably just heard of as a broken hip. So let's get right into it.
So, let's start with a question to get us thinking. What common injury is a huge life-altering risk for the elderly? Now, there are a few you could name, for sure, but the one we're digging into today is right at the top of that list. It's a fracture that can completely change the game for someone's mobility and independence.
Here's our game plan. First, we'll cover the basics, who gets this injury, and where exactly it happens. Then we'll decode how doctors classify it, which is absolutely key to understanding how serious it is. We'll look at the symptoms, the different ways to fix it, and finally, we'll really get into why this particular fracture has earned such an unforgiving reputation. Okay, Section 1, a common critical break. First things first, let's get our bearings and talk about the who and the where of this injury. First up, a quick anatomy lesson. Your thigh bone is called the femur. At the very top, you have the ball that fits right into your hip socket. Well, that critical, kind of narrow piece of bone connecting that ball to the main shaft, that is the femoral neck. It's a total marvel of engineering, but, it's also a major point of vulnerability. So who is most at risk? Well, this is overwhelmingly one of the most common fractures we see in the elderly. Women are especially susceptible, particularly after menopause, and that's because of the strong link to osteoporosis, a condition that basically makes bones more fragile and less dense. Let's move on to Section 2, and this is where it gets really interesting. We're decoding the fracture. We're going to get into the brilliant systems doctors use to figure out exactly what they're dealing with. To treat this right, a surgeon needs a super precise diagnosis. Think of it like a puzzle. They have to answer 3 key questions to see the whole picture. Where exactly is the break? What's the angle of that fracture? And how much have the pieces of the bone moved apart? First up is the anatomical location. Is the break subcapital, right under the head? Is it transcervical, cutting through the middle of the neck? Or is it basal, at the very bottom where it joins the shaft? Now, the basal fracture is pretty common. But here's the kicker. The real story is what happens the higher up that break is. Location is everything. And this quote just nails it. The higher up the fracture, or the more proximal, as doctors say, the higher the risk of 2 really bad complications. One is non-union, where the bone just fails to heal. And the other is AVN, or avascular necrosis. That's essentially the death of the bone tissue itself. We're going to explore why that happens in just a bit. Okay, what's really fascinating here is how we bring physics into the picture. Powell's classification isn't just about location, it's all about the angle of the break. The more vertical or steeper that fracture line is, the more shearing force is acting on it. And more shearing force means the break is way, way less stable. And you can see it plain as day right here. A type 1 fracture at about 30 degrees is pretty stable, but once that angle gets steeper, hitting a type 3 at 70 degrees, boom! The instability just skyrockets. This angle tells a surgeon so much about the forces they're fighting against, and it has a huge impact on the patient's prognosis. And finally, we have the Garden classification. This is probably the most widely used system of them all. This one is all about how much the bone fragments have moved out of place or been displaced. Think of it as a scale of severity. Stage I is just an incomplete crack. In stage 2, you have a full break, but the pieces are still lined up perfectly. By stage 3, they've started to shift, and in stage 4, they are completely separated and out of alignment. So, with that whole diagnostic framework in mind, let's jump to Section 3, reading the telltale signs. How does this injury actually show up in a patient? What does it look like? The clinical signs are pretty classic, and they're hard to miss. A patient will have terrible pain, usually right in the groin. They absolutely cannot put any weight on that leg. But the 2 biggest visual giveaways are these. The injured leg will actually look shorter, and it will be rotated outwards. The whole leg, kneecap and all, will be pointing away from the body. Usually, a simple X-ray is all you need to confirm the diagnosis. But sometimes a fracture can be occult. It's hidden. It doesn't show up clearly. In those sneaky cases, an MRI is the gold standard. It'll give you the definitive answer, no question. Okay, Section 4, the path to repair. So the fracture is confirmed, it's been classified. what happens next? How do you fix it? Well, the treatment path really comes down to two critical questions. First, is the fracture displaced? Have the bones moved? And second, what's the physiological age of the patient? Basically, how healthy and active are they, not just the number on their birth certificate. The answers to these two questions guide the entire surgical strategy. And this brings us to the two main surgical options. So if the patient is younger and the bones haven't shifted, the goal is always to save the original hip. Surgeons will use internal fixation, which is basically pinning the bone back together with special screws to let it heal. But for an older patient with a displaced fracture, there's a huge risk that the blood supply is already gone. So in that case, saving the original bone is a really bad bet. The better option is often a hemiarthroplasty, a partial hip replacement where they take out that damaged ball and replace it with a tough, durable metal one. And now for our final section, where we really understand the stakes, an unforgiving fracture. Why is the specific break so notorious in the medical world? The number one complication, the one that keeps surgeons up at night, is avascular necrosis, or AVN. What is it? It's the death of bone tissue. The fracture can so easily tear the delicate blood vessels that feed the head of the femur, and once that supply is cut off, the bone is starved of oxygen and it literally dies. So, this is the crucial question, right? Why does healing fail so often here? Well, the femoral neck is just a uniquely terrible place for a bone to mend. It's a perfect storm of biological challenges. The blood supply is fragile and easily torn. The joint is filled with synovial fluid, which can actually wash away the blood clots that are trying to start the healing process. Plus, the bone's outer layer, the periosteum, is missing right there, and that layer is essential for forming a good healing callus. It's just set up for failure.